his cap refill is intact. If anybody would like to shout out some differentials that are running through your mind in this gentleman.
The patient had the respiratory distress and hypertension.
Mm-hmm.
We think about the septic shock,
Yep.
hypovolemic shock,
Mm-hmm.
um, uh, maybe the shock from the heart due to the heart injury.
Mm-hmm. Yeah, good.
It's mean the cardiogenic shock.
The cardiogenic shock. Yeah, I agree with you with his tachycardia and his hypotension. We are definitely concerned about shock in this patient. And it looks like he's febrile, so it sounds a little bit more like septic shock. And then the question for us starts to begin, where is the problem? Our differential for this is pretty broad in trying to, diagnose what is going on. I agree with you. You have to think about shock. You have to think about sepsis. And as a subsect of shock, making sure that you're not missing something like anaphylaxis, especially with that hypotension and that increased work of breathing and decreased oxygen saturation. But we hope that you would be able to see, hear some wheezing or get a little bit more of a history from this patient that would help point you in that direction. But at the same time, that patient would similarly be warm when you think about your initial physical examination and have good peripheral pulses. We can think of additional type of shock, obstructive shock with the tachycardia, and the hypotension with tamponade. A PE can cause a slight fever in some patients. Any type of underlying arrhythmias that would go along with your cardiogenic shock. We don't have an EKG yet, so we're not sure. Hypovolemia, I agree we need a little bit more information to help point us which is the etiology of his shock. At the same time, we have to think of metabolic derangements that can also cause difficulties if in our circulation. Is this patient an accidental or intentional drug ingestion that's causing a cardiogenic shock or a shock-like state? Or is he supremely acidosis as a secondary event to sepsis or taking a toxic ingestion? Going along with hypovolemic shock, any signs of trauma or intra-abdominal bleeding, toxic ingestion, your medication side effects, that he accidentally just has been taking too much of his medication or had a recent medication change that he's having adverse reaction to. If he's been accidentally over-diuresed, or having additional new meds on board that are causing him to be hypotensive and dizzy and fatigued. And finally, thinking about expanding into autoimmune disorders, including myxedema coma. So this is a broad differential for hypotension. Dr. Hotu knocked it on the head with thinking about the different etiologies of shock. I didn't go over neurogenic shock because hopefully you would have a little bit more indicators if there was some recent trauma that could help point you in that direction. Similarly, with obstructed shock on your physical exam, hopefully you'd be able to pick up some of these cues. And as well as for cardiogenic, normally you would have the cooler extremities. And once we get an EKG, we can help point us in the direction of any arrhythmias or ischemic events. What tests and imaging would you like to order without having any additional history from this gentleman?
Uh, so I will indicate complete blood count and full metabolic panel.
Mm-hmm.
Uh, this man he must have the new score above 5, so I will start the blood culture too.
Mm-hmm.
In terms of imaging,
Mm-hmm.
uh, I will indicate the X-ray for finding the infected site and focus.
Mm-hmm.
Uh, and in Vietnam, there's we usually when when the patient in critical condition, but initially we can't find any infected sites. So we also indicate uh, the dense virus antigens.
Mm-hmm.
Yes, because we are the epidemiological area.
So you're thinking about additional viruses because of the epidemics,
Yeah,
the
yeah, yeah.
etiologies for your area. What kind of things do you guys normally go to on your viral panel, if you don't mind me
Yes,
asking?
the dengue virus.
Dengue virus. Okay.
Yeah, dengue. Yes.
Okay, I see. And then do you use lactic acid or routinely get either an ABG or a VBG to help you in these patients? Besides, I agree with you with the complete blood count and the metabolic panel and getting the chest x-ray and using your ultrasound and getting blood cultures. Is Do you guys routinely use a lactate or is that not and a blood gas or are those things that not don't come back very
Oh
quickly?
yeah. Oh yeah. Yes. Yes.
Okay,
We did usually do ABG.
perfect. Okay.
Uh, and then also about metabolic panel. I want to emphasize that we also do the uh, the test that we can evaluate SOFA score.
Okay.
That is yeah, bilirubin and also lactate.
Lactate too. Okay.
We can see on it.
Perfect. And what kind of things are you looking for when you use your ultrasound?
Um, First of all, I want to evaluate the breast protocol.
Hmm. Okay.
I will evaluate the heart, IVC,
Hmm.
the lung,
Hmm.
and also finding the infected site where I will looking for children looking for his kidney and the uh, cholecystitis.
Cholecystitis too. Okay. As part
Yeah,
of kind of a modified rush exam, the
yeah, yeah,
places
yeah,
where you
yes.
can see on the ultrasound, you look. Okay.
Yeah.
Perfect. Yes, I agree with you with all of those things. As we said, the CBC, your CMP, and it kind of depends here on if you are concerned for any intra-abdominal process, if you're throwing on a lipase, if you're concerned for any necrotizing pancreatitis picture. Things I would additionally add on here are probably a urine with a urine culture. And I, like we talked about already with blood cultures, the blood gas, a lactate, chest x-ray, and then I agree with grabbing your ultrasound early. Perfect. So we get a little bit more history on this gentleman because we've started getting some lab work done. He's getting his EKG as his wife comes up and tells you that he's having a fever. He's been getting tired very easily, has been generally weak and short of breath, and he just can't do what he used to. She says that this has been going on for a week and he's been having fevers and chills at home. He's not eating as he normally does. No one else is sick at home, but he doesn't have any chest pain, no extremity swelling, no wheezing, no recent travel, and otherwise his review of systems is negative. On your physical exam, he looks ill. He's able to speak to you in full sentences. He's tachycardic on your exam, but again, he has good cap refill and good pulses in all of his extremities. He has clear lungs, but is slightly tachypnic, and he's noted to be warm and clammy without any evidence of rashes on your exam. This is our EKG. What do you see?
Only see the tachycardia, no see there's any sort of ischemic heart disease, right ventricular strain.
Mhm. Yeah, I agree. I see sinus tachycardia. I see no signs of ischemia. Um, I don't see any big rightward axis shifts. So the CKG is helpful at telling us things that it is not. What is our chest x-ray showing us?
Pretty normal to me.
Mm-hmm. I agree. And you think to yourself, he's been pretty easily winded and he's breathing a little quickly. I thought, he was going to have a pneumonia, but his chest x-ray is clear. I'm not seeing any fluid overload. It actually looks like maybe this person had some underlying COPD because these are very tall lungs and a narrow cardiac silhouette, but otherwise looks pretty normal. We get our labs start to come back. It looks like we have a significant white count, but luckily he's not anemic. You do have a little bit of a metabolic acidosis if we're using a bicarb normal of about 24 or 26 here. His coags are normal, which is something that we typically get also during our sepsis panel. LFTs are normal as well as lipase. And it looks like his urine might be the culprit today, as well as he has an elevated lactate. Now, with all of that in mind, what interventions would you start to perform for this gentleman? Remember, he is tachycardic, hypotensive, and it looks like we may or may not have found a source for our infection.
So he he's tachypnea and also his SpO2 is a little low. So I will start it with uh, nasal oxygen
Okay,
and to lab for IV assess with
perfect.
with fluid bolus, maybe around to 1,000 millimeter in an hour. And with this test, it indicate that his affected site is uh, uroneurology.
Mhm.
So I'm I will start it antibiotic also. One the first type of antibiotic I may choose the beta-lactam with beta-lactamase,
Mhm.
maybe the tazobactam and uh, uh, biberacillin, and one quinolone. So I will choose the ciprofloxacin uh, for the infected in urology system.
Okay. So it sounds like two antibiotics, if I got you correctly.
Yes.
Okay. I agree. And then how you said 1 liter of fluid. How did you come up with that number? Is there a specific driving amount that there is maybe from a reading from this week that we could
Mm.
think about giving the patient a specific amount of fluid?
Yeah, I use the 1 hour bundle of the Survive Sepsis campaign guide. So
Perfect.
it recommend that we start it first with the 30 millimeter per kilogram per kilo
Mhm.
in the first 3 hours.
Yep.
Mm.
Yep, you got it. Your patient's blood pressure responds very nicely to your fluid bolus. He thanks you for your help. And where is this patient going? So big picture, Is he going home? Is he going to a general medical floor? Is he going to an ICU bed?
It depends, but with sepsis and elevating lactate,
Mm-hmm.
he must have septic shock. I think I will transfer him to the ICU for close monitoring.
Yeah, I agree. You did all of those interventions pretty quickly, and sometimes these patients they're very tenuous and they can go south very quickly. So let's do our first question. Kind of going off of the reading from this week, which of the following is not a sign or symptom of sepsis? And you can either type your answer into the chat box or you can say it out loud. Okay. Great job, guys. I know that one, it's an easy one. We're starting on that easy this week. You guys are right. So it's definitely A. What are we looking at with this collection of answers here? If we are saying the temperature maybe was 38 instead of 37C, if your respiratory rate was elevated and your white blood cell count was elevated and you were tachycardic, what kind of criteria are we trying to get at with this question?
It's look like the SIRS
Mhm.
criteria.
Yep, it does. You are correct. It looks exactly like the SIRS criteria. Good job, Dr. Blumenthal. Yeah, so I like to think of the SIRS criteria as anything on either end of the spectrum that is abnormal. So people often forget when our patients come in hypothermic that you still need to think about sepsis, that it is still a dysregulation of your system, not being able to maintain homeostasis. So even when your patient, is 35 degrees Celsius and they say, oh, we're just throwing a blanket on them, I think it's okay. You still have to have that thought in the back of your mind. Same thing with the heart rate. So tachycardia, I still think about, if you're concerning point for cardiogenic shock in the big picture. If someone has just recently had any cardiac procedures, especially something open, this is still something that has to go through your mind if they need any antibiotics and if they need blood cultures. Similarly, we talked about respiratory rate or leukocytosis or leukopenia. Something that I don't see as much, but I have to remind my residents is to look at the bands. So if you're having any leftward shift, not just neutrophilia, but any bandemia is also meeting SIRS criteria, which just because over here for us, it takes a little while for our differential to result. People I found have often missed looking at the differential for the bandemia. Going back broadly, sepsis, it's a life-threatening dysfunction, as we said. So dysregulation of your homeostasis of the body in a response to some sort of infection. People with sepsis, as everyone here knows, have a very high rate of in-hospital mortality, which I believe is why you suggested an ICU for this patient with a tenuous hemodynamic stability. It's about 20% of all deaths globally. The subset of sepsis, where our patient was, septic shock, where you're having circulatory collapse and organ dysfunction. It's a greater risk than sepsis in and of itself. So going a little bit back about the Surviving Sepsis campaign, which is a little bit about what this talk is about. Starting back, all the way back in 2002, societies came together to initiate a set of guidelines because they found a really high mortality rate around their patients with sepsis and septic shock and thought that they could make one overarching criteria with about 11 international society coming together to make a standard set of guidelines to help improve patient care. So in 2000 and we get our first publication of guidelines for sepsis and septic shock. And this was disseminated through critical care medicine and intensive care medicine magazines. We move forward a little bit more to 2008, which was our first update on this, and it incorporated a lot more societies and more feedback from different disciplines, including emergency medicine. In 2012, we get our second update, which is where we start getting this revised sepsis bundle criteria. I don't know if you have the same at your hospital for the guidelines about hearing a lot about the sepsis bundle and a very big attention to the timeline and how quickly we're able to initiate interventions on these patients, knowing that it has an effect on mortality. And then going up to what we're going to focus on today is in 2021, we have some significant changes to the Surviving Sepsis Campaign guidelines, including going from QSOFA back to a SIRS criteria, how quickly we need to initiate our antibiotics and our fluid resuscitation, and some suggestions about antibiotics and a few other adjuvant therapies. So those first couple of iterations of the Surviving Sepsis Campaign focused on using SIRS, as we said earlier, as the identification for sepsis. So seeing on either end of the spectrum any dysregulation in the body, so temperature again, heart rate, any tachypnea, or any leukocytosis or leukopenia. Then we got to around 2012, and we introduced the idea of QSOFA as a different criteria to use to help determine if patients met a sepsis criteria and to try to help determine what their mortality in the hospital might be and differently try to stratify them. As of 2021, our recent guidelines came back with 93 total recommendations. As we said, some of this was going off of the timeline of how quickly to perform your interventions. So if somebody definitely has sepsis, has all of those SIRS criteria, and has a known source of infection, the recommendation is to try to initiate those antibiotics within 1 hour, especially if the patient has septic shock, but within 3 hours if there is concern. They're still recommending the 30 milliliters per kilogram bolus within the first 3 hours of resuscitation. They suggest instead of using non-invasive oxygenation, they recommend high-flow nasal cannula as first line for hypoxia. So something I learned when I was in medical school is using vitamin C that had some theory of improving mortality in your patients with sepsis. They are recommending against using vitamin C, at least in the IV form for your critically ill and patients who qualify with sepsis. This next one is about informing families and patients about what is actually going on, what the concern is for sepsis, and the higher mortality, and what to look out for when they're able to go home. As we said, they're recommending against the use of QSOFA as of 2021 and moving back towards a SIRS criteria for diagnosis of sepsis, moving towards vasopressors early through a peripheral line and not delaying its use if you were hoping to get a central line in beforehand. They recommend initiating the vasopressors peripherally while you anticipate and set up to get your central line done. And then suggesting corticosteroids for those patients with refractory septic shock and have additional vasopressor requirements. They have some additional recommendations. I had sent in the deep dive. It is a very lofty read if you had time or wanted to, but it has further suggestions about the capillary refill time, suggestions about antibiotic coverage for broad spectrum, especially if you don't have all of your information yet. And depending on your emergency department and your lab turnaround time, if you're trying to meet that sepsis bundle timeline of within 1 hour for concern for sepsis, you don't have time to pinpoint a site of infection going for broad spectrum, and especially covering for MRSA, being concerned and considerate about possible fungal infection, like your chronic indwelling Foley catheters who might be colonized with it. Again, the peripheral vasopressor use, high flow nasal cannula ECMO use, and then they have some guidelines for those who work in the ICU for post-ICU follow-up care. So that's a lot to just say. If we go down to the basics, it sounds like still using Q-SELFA. So there's a lot of overlap here. It looks like Q-SELFA was focused on the overall hemodynamics, so looking at the blood pressure, whereas SIRS doesn't have that incorporated into it. I think that if you're taking both of them into account, you will do well in identifying your patients with sepsis, and any large derangement in your hemodynamics, I feel confident that you would understand and be concerned about a shock state in that patient. But they are recommending now using SIRS instead of just the Q-SOFA score, 1 through 3. So approach to sepsis, this is, the stepping stones of sepsis. Is it just a SIRS, or is it sepsis because you have a SIRS element that is flagging and a suspicion of infection? Or are they, just dehydrated because they ran a lot outside and they're inappropriately flagging a sepsis alert for you? Or are they, severe sepsis where they're having signs of dysregulation or septic shock, where they're now to the point where they are having organ dysfunction and hemodynamic instability? So you're already screening everybody with your vital signs. It's just then putting them into these specific buckets so that you can help provide targeted interventions within the timelines that are recommended, and then being able to provide broad enough antibiotics or narrow enough coverage, as well as thinking about source control to help your patients. And then we spoke about early goal-directed therapy, meaning your early interventions with fluids, your constant reassessments, and early use of vasopressors if necessary if you are not getting a good response to your fluid bolus. So this is just kind of going off my personal approach to sepsis, which is a lot of words on a page. So you're getting your initial resuscitation. As both Dr. Vomunka and Dr. Hotu said, you get your ABCs, you get your 2 large bore IVs, you fix the derangements you can fix. If they're hypoxic, put them on oxygen. You do fluid trials. You do have to think about the background of your patient. There is a caveat for your 30 mils per kg fluid bolus for your patients. If your patient already appears fluid overloaded and you've looked with your ultrasound and they have a plethoric IVC, if they have B lines on their chest, if they don't have a great EPSS, this patient is not going to do well if you flood them with fluid, and you're going to have a much harder time resuscitating this patient. You can give them fluid trials in smaller doses, and you need to be aware of their background if they are cancer patients, if they have ESRD, if they have cirrhosis, pulmonary hypertension, or CHF like we talked about. Bedside POCUS, I agree with the modified rush and looking at the sites where you can look, especially if it's going to be a while for any definitive imaging. Early blood cultures, urine cultures, and chest x-ray. If someone is on my radar and I can't, on the history, point to a likely source, I will go for broad spectrum antibiotics early. And then with the hope that after the blood cultures within 24 hours, my colleagues on the medicine ward or in the ICU can help to downregulate their antibiotic care. At this point, after they have their initial stabilization, we've given them a fluid bolus. If they came in hypotensive, hopefully they are responding to fluids, and we've started some antibiotics. Go through and chart review again. So after getting that initial history, go back and look at any concerns for their renal functions, any recent medication changes that may be contributing to this, or any recent procedures or instrumentation. After this, I'll go back and reevaluate. So getting a repeat lactate after your fluids interventions. Are they fluid responsive? Do I need to start a vasopressor? Do they have a source that I need to now speak to a colleague about? Meaning, do they have necrotizing fasciitis? Am I concerned about a septic joint? Are we concerned about an intra-abdominal process that would need surgical intervention? Because at that point, that's not something I unfortunately can do, and always there to ask for help. Okay, so you've given them one dose of vasopressors. They're on norepinephrine. and I go back and they're still hypotensive. At this point, I go through it. What did I miss? At this point, it's a very thorough skin exam. Sometimes you need a lot more help to thoroughly turn the patient and be able to look to evaluate for any Fournier's or any concerning cellulitis that you might have missed on your first initial exam. At this point, if I'm adding a second vasopressor, I look to see if I need to do vasopressin versus an ionotrope, depending on what their EPSS is and looking at the squeeze of their heart. If someone is on chronic steroids, meaning more than 20 milligrams a day for your patients with autoimmune disease, or a lot of our COPD patients who can then get put on chronic anti-inflammatories, at that point, I will add on a low dose of steroids. And then think about additional imaging. If initially I did not get a CT scan and a lactate is significantly elevated and is not decreasing with fluid interventions, at that point, I will get a CT of the abdomen and pelvis. And if there was any derangement on the chest x-ray, I would include a chest x-ray. And additionally, if they're altered, thinking about meningitis coverage, if this is something you now need to broaden to an acyclovir and get ready to do an LP. Does anybody have any other different practices that we did not go over here? Dr. Nonley, were you, I know you're working. Were you motioning to other people or to us? I think maybe to other people. Okay. We will continue. So this is taking from the Surviving Sepsis campaign. Again, they are focused very much on the timing of their sepsis bundles. So how quickly we are providing these interventions has shown to have a direct impact on patient mortality. So sepsis, if it's definitive or probable, if shock is present, they want everything done within 1 hour. So early recognition, early antibiotics, early fluid resuscitation. If shock is absent, so they're hemodynamically stable, ideally, if you have a source of infection and you have an idea of where it is, they would still recommend within 1 hour, but at least within 3 hours if you're concerned for a persistent infection. So vasoactive management also, they recommend across the board using norepinephrine as the first line, targeting the MAP of 65. And then considering placing an arterial line if you are starting a vasopressor, if that is within your practice. And at that point, they're going to an ICU, and your ICU colleagues may appreciate that extra monitoring. If you haven't yet gotten central access, that is okay. Start your pressors peripherally and then start getting ready for your central line after getting those pressors on board. And then if they are still hemodynamically unstable and you've done your ultrasound and they see any dysfunction, cardiac dysfunction on there, consider doing an ionotrope, so dobutamine, or switching to epinephrine from norepinephrine for that extra ionotropy. So this week, we're focusing kind of on the 0 to 6 hour effect, just identifying your suspected sepsis, using the screening tools that are available at your hospital, if that's SIRS, QSOFA, or a combination of the two to make sure you're not missing any possible sepsis, starting your broad spectrum antibiotics early, ideally within 1 hour, 3 at the latest, assessing the need for source control early and the need to contact your colleagues, providing fluid challenge and boluses, and early interventions with vasopressors for support. Next week, we'll start going into the further considerations for low-dose corticosteroid supplementations in your refractory shock patients. And then this 24 to 48 hours, hopefully the patient is out of your department and you are no longer taking care of them. If they're still in your department, I have big faith that you guys have already fixed most of it, and then hopefully you're getting help from your colleagues at that point. I wanted to talk a little bit about biomarkers and see if this is something that is integrated into anyone's practice routinely, about using inflammatory markers such as CRP, ESR, procalcitonin, preseptin, beta-D-glucan, or any diagnostic markers to identify sepsis or to try to help predict mortality. So in my practice, I know that I use the ESR and CRP if I am concerned about a recent instrumentation, especially in somebody who's had back surgery or any joint replacements. If I am concerned about a septic joint, I will often go for a CRP and an ESR first. These I reach for more readily also in my pediatric patients because it seems like there's a little bit more data surrounding pediatric sepsis and the correlation of the inflammatory markers. Procalcitonin, I personally use in the era of COVID, where you have a patient who is also at the same time COVID positive, but they are having hemodynamic instability. And it's hard to tell on the chest x-ray if your patient has an underlying secondary pneumonia or if they have just COVID. Molly is asking to the group if you use procalcitonin at CHORI.
In our hospital, in Thống Nhất Hospital, we usually, when we suspect someone who has sepsis or septic shock, we usually almost always use procalcitonin to diagnose and treat the patient. I'm sorry for the inconvenience.
No, there's no inconvenience. We thank you for joining us. I realize that your schedule is very crazy over there. So thank you for making time to join us. We always appreciate your input. So yes, I agree. There is a lot of literature and some newer literature going between the presepsin and the procalcitonin about early detection of sepsis because it focuses on, mitochondria dysfunction and this oxidative stress, and then subsequently changes in your protein metabolism. And we're looking at those metabolites as kind of our markers for underlying dysfunction. For this. Presepsin has an interesting amount of literature around it right now as it's a lipopolysaccharide that's found on gram-negative bacteria. So there is some literature that's saying that it's a little bit more helpful in early identification of sepsis in gram-negative patients when compared with procalcitonin. But both of those are acute phase proteins that are elevated early in sepsis. Over on the right side of the screen are some diagnostic markers that are not ready for prime time yet, but are being investigated to see if they can be used as diagnostic markers for early identification of sepsis, and then to further be used to help predict mortality rate in these patients. But as of right now, procalcitonin, can be recommended as an adjuvant for sepsis detection, but per the surviving sepsis guidelines, they don't recommend using it to direct therapy. But I would argue if you are on the fence between a viral etiology of your patient, for example, with COVID versus an underlying concern for pneumonia, I believe that they use that for further direction of therapy when they've been admitted to the hospital. What kind of special considerations do you have to think about for your patients? We kind of went over this topic earlier, meaning what aspects of their history, what aspects of a physical exam would help change any of your interventions that you would normally do in let's say, a 35-year-old patient who came in who had pneumonia versus somebody who is 65 and has, renal disease or dialysis. So besides a dialysis and stage renal patient, what other special cohorts of patients do we need to think about, and what other evaluations do we need to consider?
But in the older patient, sometimes they may not have a typical symptom. No fever, no coughing.
Yeah.
Only a slow contact. And then special consideration, the cancer patient.
Yeah.
Children. Because I don't know in the other hospital, but in my hospital, we still treat the children.
Children?
Children.
Children, yeah. Okay. Yeah. No, I agree with what you said. You for the special considerations, especially are those, as you said, the cancer patients or any immunocompromised patients who might not mount a fever, who might not mount that white count. And sometimes you have to look at the trend and see if their white count, although within normal limits of your laboratory test, is actually significantly different than what their normal is. We kind of went over thoughts of signs of fluid overload that would change how you approach that initial fluid management. In your cancer patients and those who have indwelling lines can also dictate how you're doing your early microbial interventions if you're needing to cover for MRSA with any indwelling lines, PICC lines, central lines, and any peritoneal dialysis catheters. If your patient has cirrhosis or gets peritoneal dialysis, is this someone who you're going to have to think about doing a paracentesis on early to see what type of antibiotics will be driving your management of your patient? Along with those who are immunocompromised, thinking about earlier use of steroids because any stress to their system could be very tenuous in their situation and tip them over the edge, and their adrenals might not be able to appropriately compensate. Any patients who are already on anticoagulation, some of what we're looking for in sepsis management, we need to be concerned about patients who are at risk of going into DIC or having platelet and coagulopathies as a secondary result of their sepsis, and looking at glycemic control, especially in your diabetic patients. You can't get good glycemic control. It's going to prolong healing time and make it difficult for source control. So I don't know if you guys have the Michelin Man over there. That's what I think about when your patients are puffy and we give them more fluid. So this Clover's trial is pretty recent. It looked at early restrictive or liberal fluid management in those sepsis-induced, who had sepsis-induced hypotension. I have some comments about the way that this trial was done because already after 4 hours, the patients had between 1 or 3 liters of fluids already on board. And then afterwards were placed in either a restricted fluid arm versus a liberal fluid strategy. In this trial, there did not seem to be a significant difference in mortality for those who were able to be discharged at 90 days compared to those who had liberal fluid strategy. The information of the Clover's trial is down at the bottom of the screen if you would like a more in-depth reading of it. But as I said, my concern is for those first, hours when they're in your emergency department and how much fluid you're given, depending on the size of the patient, going from 1 to 3 liters, using that as your criteria for how much fluid they've already received to include them in your trial. I don't know if that, for me, changes my practice on providing them with liberal versus restrictive fluid strategies. Has anybody else had different thoughts or journal club discussions about this trial?
No, before this trial, I think many patients die under my hand due to the over fluid bullets.
Yeah, that's always my concern too. I don't want to drown my patients. So, okay, we have 2 more questions, guys, and then we'll be wrapping up for the evening. So most common cause of sepsis. This question is taken from a question bank that is directed mostly for the United States. So it may be different than what we see for you guys. Gram negative. Okay. Okay, gram negative. All right. Yeah. So it looks like, yep, gram negative. And then on the left are, the common ones. So E. coli, if we're having GI upset, versus a lot of the times our uroseptic patients are coming in with an E. coli sepsis, often concomitantly with a Klebsiella I've seen in the urine, or if you have your patients who are unfortunate enough to have 2 sites of infection with a pneumonia and then they've forgotten to hydrate adequately or haven't remembered to get up to go to the restroom, and now they also have a UTI. Always thinking about more than one source of an infection for your patients, especially if they're refractory hypotension. I thought this would be fun to include. I don't know if anyone recognizes any of the names on these papers. These papers were both done in Vietnam, in Ho Chi Minh City, at least one of them at Cho Rai. The first one talked about factors associated with the mortality of septic patients in the ICU, kind of showing what the mortality rate was. This looked at the QSOFA score and the Apache scores and found correlation between higher scores and higher mortality risk, which makes sense. And they determined that the highest rate of mortality at the site were those with pneumonia. I don't know if that is still tracking after the data it looked like was collected around 2019. I'm not sure if that data has changed since COVID. And then in the second article is a 2022 retrospective article where they looked at the positive blood cultures and then looked at the culture-directed antibiotics that were provided. And as we looked at gram-negative at the sites were the main culprits. And they actually had a pretty high resistance to ceftriaxone. I don't know if at either of the sites that are on tonight, if that has changed how you are treating your urinary tract infections or your intra-abdominal infections. Because I know for us, our first line for urinary tract infections and a lot of other infections right now are to give someone ceftriaxone. What is the first line for your uroseptic patient for antibiotics? I think we had talked about a ciprofloxacin earlier with Dr. Bowman. What was the second antibiotic coverage that you would give for the urinary tract infection besides ciprofloxacin?
So I will aim for the gram-negative bacteria. So my choose is if the patient isn't having any risk of multiple resistance, I may start with ciprofloxacin. Yes, which is aiming for the gram-negative bacterial.
Gotcha.
If the patient have risk of exposure to MRSA, I may consider either vancomycin or linezolid instead of ciprofloxacin. Yeah.
Perfect. You also brought up an excellent point, especially with our uroseptic patient, of looking at what they have previously been cultured for and see if that needs to direct our antibiotic regimen moving forward. And our final question to kind of lead us into next week: what are some considerations for refractory hypotension and septic shock? Perfect. Yeah, so looking at this, we have sepsis, and as we talked about at the beginning, it causes dysregulation of your homeostasis and organ dysfunction and septic shock, which causes endothelial dysfunction, which can make things leaky. You can get hypotension from third spacing and then poor perfusion. You can get the coagulopathy and secondary DIC, which is why I recommend checking the coags on your patients. And at that point, you would also get a decreased capillary refill. At the cellular level, you're getting cellular dysfunction. They have increased catabolic state. They're higher oxidative stress and metabolic turnover. And then also thinking about your cardiovascular dysfunctions if they're having any under cardiac diseases. And then we had also kind of gone over at the beginning, thinking about your mimics of sepsis as well. If someone is refractory to my initial vasopressor, thinking about if they're having a supreme metabolic acidosis where some of my medications are not going to be optimal for them. And then thinking about when to throw on a TSH, thinking about any mixed edema comas earlier with refractory hypotension. So in summary, screen early, look at all of your vital signs. They are vital for a reason. Do your ABCs, fix those things that you can fix early. Try to get appropriate treatments and labs sent off within an hour, 3 hours at the latest if they are not in shock. Looking at an accurate fluid balance. So looking at the whole status of the patient, using your adjuvants with ultrasound when you're able to help direct how much fluid is appropriate for your patients. Look to think when you need to call for help for a source control for any surgical interventions. And remember glycemic control and additional reasons why your patient may be in refractory shock, including autoimmune, hypothyroidism, or adrenal insufficiency. Okay, thank you. Are there any questions before we end for the evening?
I just have a small question. In Vietnam, sometimes the patient have the septic shock or septic and need the surgery intervention. But when we call about the surgeon, they just told us we need to control the septic shock. It means the life of patient much better before the surgeon will do it. Will do something. How about in your country? Because I think if we cannot control the infection, very difficult to control a sepsis or septic shock.
You bring up a point that we also have here with our surgery colleagues, the discussion of are they too unstable for surgery or are they unstable because they need surgery? I've seen this more often than not, unfortunately, when patients have necrotizing fasciitis and they need to go get source control in the OR. I think Fournier's is the #1 reason I've seen this. And then second to that sometimes is a discussion with interventional radiology when you have really bad, like necrotizing cholecystitis or a gaseous cholecystitis. I look forward to any suggestions you guys have for dealing with your surgery colleagues, but unfortunately, at that point, sometimes it's also a discussion with the anesthetist to see what the patient can handle if they think they are also too unstable for surgery, and at what point, what level is stable to be able to take them in. But I agree with you. Unfortunately, that's a conversation we often have here too. Okay.
The same problem, huh?
What was that?
The same problem with us, huh?
Same problem, different place. Okay, thank you all. I will see you next week. Look out for the email with the topic and some reading. Have a good rest of your day. Goodbye.
Yeah, thank you for your teaching.
Thank you.